So now I'm going to hand over to Tom, who is going to be chairing the rest of the session and moderating the discussion. So over to you, Tom. I'm going to mute my microphone.
Thank you very much, Peter. And just to remind friends to mute their microphones until they want to make a contribution. The site details will be on the resources for the webinar, and we'll put them up again at the end of the end of the discussion. So I am a disability researcher. We know that half of all disabled people are older people, and I also do work with people with dementia at the moment. So I'm very interested to be part of this webinar, so thank you for inviting me. Can we have the next slide, please, Lucas? So we have 3 excellent speakers. As I said, each will speak for about 15 minutes. We have John, who will make general comments, but particularly from the role of international organizations, former director of the Department of Aging and Life course at WHO, which is where I first had the honor to meet him, but you'll all know the work that he's done in different settings. We have Jane Barrett, who's from the International Federation of Aging, looking at what the high-income country situation suggests, maybe the warning for low and middle-income countries. And finally, we have Sridhar Venkatapuram, who's going to be talking about social justice. He's a theorist who's talked generally about global health policy and ethics, and I look forward to him. So let's go straight then to John. Could you unmute, and I will set the...
Tom, I've lost you. I don't know if you can hear me, but okay.
Yes, we can hear you.
Go ahead. Great. Okay, so greetings, everybody. I'm in lockdown in France in a small cabin with my 5-year-old son. So if I get disturbed in the middle of this, you'll understand what's going on. I'm going to talk about ageism and COVID and a little bit about international organizations. I don't want to focus on that too much, as I think it would be rather boring. And I'm also going to try to broaden our understanding of how ageism has had its impact on where we are at the moment, beyond the discussion that which seems to have sort of dominated the last couple of weeks, which is access to ventilators and critical care, and the rationing that's occurring, and age-based excuses for using that rationing, because ageism. The impact of ageism started a long time ago, and the origins of this impact are much more basic. They lie in the fact that we have health systems which are not designed for the needs of older people, but basically have their legacy in systems which were designed for acute conditions, whereas most older people have chronic conditions. The origins lie in our failure to establish comprehensive systems of long-term or social care and to integrate that with health systems. And so what we have had over the years is a systematic neglect of the needs of older people for a range of reasons, which we will probably discuss over the next hour or so. And I think that is exemplified by what happened in the United Kingdom, where there seems to have been a political decision made relatively early in the outbreak that, okay, let's let the virus spread throughout the community and just ask vulnerable people to self-isolate. And the absurdity of that is that vulnerable people are actually not in a position to self-isolate. How do they get the care they need safely? How do they get the supplies they need safely? And so on. And in the United Kingdom, there'd been an almost systematic dismantling of those support mechanisms over the last 10 years. And so on the one hand, we have the idea that, okay, young people are somewhat immune, or not immune, but more resistant to the virus. And so we can cope with them getting sick, and we'll just leave it to older people to self-isolate. I mean, this is fundamental ageism. That's a very stark example, but I think, as we just heard in Brazil, there's still this sort of attitude that's very widespread that older people are expendable and younger people are the people we need to be focusing on. So then if we look at, well, international organizations, what role do they have in all of this? And I think to start off with, it's important to understand what international organizations do and what they can't do. And international organizations such as the World Health Organization, particularly, which is responsible in the guiding the response to the pandemic, or the United Nations, are membership organizations. Their membership is the countries of the world. And so WHO has 194, I think, member states who basically control the organization. The organization has no direct control on what happens in those countries. They can't tell a country what to do. All they can do is to provide guidance on what the evidence suggests is best practice, what are the goals, and they can bring people together to develop shared goals, such as the Sustainable Development Goals, for example. And so their relationship is not a hierarchical one. It's one where they engage with their members. They try to draw on all the expertise that's inherent in those countries to come up with advice on the strategy that member states should be following. And so their authority comes from the excellence of the work that they can do, particularly when you're talking about a technical organization like WHO. Now, one of the problems is WHO, I think, has become more political over the last few years, and there's been less of an emphasis on that technical expertise, which gives it that credibility. Another challenge is that even though WHO is quite a big organization, it actually relies on outside experts for advice. So when you have an issue like COVID, WHO doesn't have a small group of people who come up with the solution and then tell member states what to do. What it does is convene experts from around the world, making sure they're properly representative of the different countries that are involved, and have all the reliable expertise that's needed. And then they look to them to provide guidance on what should happen. That sometimes takes a little while. In the case of COVID, actually, I think they convened their expert panels very quickly and they got advice very quickly, but it may not be quick enough to keep some people and particularly journalists happy. Because they misunderstand what these organizations can do and how they're constituted. Now, having said all of that, and in summary, I would be saying I actually think WHO has done a pretty good job. And I totally disagree with Mr. Trump's take, which I think is just a way of sidetracking attention from his own failings. But having said all of that, I think these organizations are inherently ageist. They have ageist bylaws, for example. They retain mandatory retirement age at absurdly young ages. They set age-based goals that tend to exclude older people. So some of the goals around non-communicable disease really were only measured if people were younger than 70 years old. And within them, they have minimal and, in fact, if anything, shrinking capacity targeting directly towards aging issues. The other, I think, key role that they have, and one where there's been a major failing in relation to aging, is low and middle income countries. The international organizations bring every country together, and that provides the opportunity to provide support and refocus some of the priorities for low and middle income countries. And there's been very little effort in trying to get low and middle income countries understand that population aging has been an issue for them, and in helping guiding them to develop the systems that I was mentioning earlier of health systems, long-term care systems, which would have enabled them to respond in a much better way to this pandemic. So I think what the real challenge and where our discussion, I mean, as well as making sure that the current response is there is as little ageism influencing it as possible, I think what we should also be thinking about is the future and post-COVID. And I have I've got real concerns that we're going to emerge into a world that is where countries are very poor or impoverished by the money they've been spending on this response, where there may be a lot of intergenerational tension, where politically people may play up the fact that we're spending all this money to protect older people, and younger people are now left with the legacy and the burden to carry for the rest of their lives. So we risk a real splitting of society and real intergenerational tensions. And I think also, while there's likely to be an emphasis, a greater emphasis on health and science, I worry that it's going to be on pandemic response, on hospital response, and on infectious disease control and vaccination. Whereas really what we should be thinking about is how we build integrated care systems that ensure that they provide coordinated response to the needs of older people. I also think as we move out of it, I would hope, and this may be one of the ways where we can start to really tackle ageism, that we start to get a better handle on what is biological age as opposed to chronological age. A lot of the guidance which we've had so far assumes that everybody of a certain age have the same characteristics, the same risks, the same vulnerabilities, and should be treated the same. Whereas really what people are trying to talk about is a vulnerability that people may have that's linked to that age, but that's only a very loose link. And I think we're on the verge of being able to have better objective measures, which would be useful to feed into the future system. I think we're going to see that technological innovation is something we have seen things change very quickly. We're having a Zoom video conference. I think a lot of that will be here will be here for good. And I think older people have actually adapted very quickly to that, and a lot of older people are engaging in the internet, for example, in ways they've never done before. So I think that will be in the future. And I think that also, I do a lot of work these days with the private sector, and I've been really impressed that the driver of many of the major corporations of the world, yes, they're there to make profit, but they also want to add value to the world. And that when they talk about the things that they're doing, it's not that, oh, we're doing this and it's going to make us a lot of money. It's we're doing this and in the sense that it's a way of contributing to the social good. And so I would hope that we can bring all of those different things together to have a much more cohesive, holistic global situation where we have intergenerational solidarity and we can put in place the infrastructure which will help us not just to combat pandemics of the future, but also ensure that the health and well-being of older people and people of all ages is adequately met. So Tom, I'm going to leave it there and look forward to the discussion we can all have.
Thank you very much indeed, John. And thank you for keeping it to 10 minutes. And I do remember that when we were working at WHO, it was always shocking to me how small your department was, given the size of the aging issue for all health systems. It seemed to indicate a lack of priority. I know you did a lot to build that, and it's very important that that's there. So next I turn to Jane Barrett. Jane Barrett is from the International Federation of Aging, and I ask her to unmute and to present her thoughts.
Look, thank you very much, Tom, and thank you, Peter, and your team for the opportunity to be part of this important webinar. This is just a slide about who IFA is, but I wanted to make my opening remarks in such that COVID has become a preoccupation of my life. And from the time I get up to the time I go to bed, I'm receiving and giving out news around COVID. From the time I talk with my 92-year-old mother in Australia at 3 a.m. So it's touched all of our lives in a very unique way. But, this havoc of a pandemic has been in some of our lives before, in the HIV, AIDS days. But I think the difference is that it is touching those lives that have never been touched with HIV and other pandemics. And that's what makes it so unique, but so important for us to be part of that conversation. I think also we will see that at some stage, as they say, the curve flattens, etc., etc. But I think what's uniquely in my mind and heart is the carnage that will be left behind. And we will see it in our own family, in our country, but the carnage in low and middle income countries, I cannot even get my head around. So next slide, thanks, Lucas. I just bring some thoughts today about, reflections on ageism, but also a little broader. I want to take you back to 2015 and the World Report on Aging and Health, and also, you know, the Executive Board decision this year around the decade of healthy aging. Just in this report in 2015, you know, there was a comment about the HIV/AIDS pandemic and the need for rapid expansion of healthcare workforce and also task shifting. So what I'm suggesting is that there's lessons that we should have learnt in the past that clearly are not being taken forward. You know, in the decade of healthy aging, it is more important than ever before that we look at what's happening now and link it through, you know, ageism, long-term care, primary integrated care, and age-friendly cities and communities. Because what the good is coming out is the willingness to learn from one another, but examples of good practice. Thanks, Lucas. Lucas, thank you. And you can put all of these headlines up. Thanks, Lucas. You know, these are some of the headlines that I've taken just in the last couple of days. And you wouldn't really be able to work out whether they come from low and middle income countries or come from the sophisticated countries, you know, the developed world. You know, but I was really struck, you know, about the messages that we're actually talking about in developed countries like social distancing, and you'll see in a later slide, you know, test, isolate, trace, which make no sense at all in low and middle income countries. You know, social distancing, a luxury that workers on $2.79 Canadian a day. You know, and we fail to remember, I think, that while this pandemic is pillaging populations across the world, you know, natural and man-made emergencies are still happening. And I think that when we think about what is the action, there has to be a balance as to what are the emergencies that we need to still be addressing at the same time as addressing people in the thick of this pandemic. Touching on what John said, you know, this tension between young and old and the intergenerational competitiveness in terms of the allocation of services. You know, ageism is affecting younger people. You know, the term vector is being used for a younger person. Those people that are in the community not listening or acting in terms of social distancing and being potentially asymptomatic. So I think if we're talking about ageism, it needs to be across a broad spectrum as an opportunity to come together. Thanks, Lucas. And you can put all these up as well. You know, some of the, yep, that's great. Some of these I know intimately and some I see from afar. But the image there is Singapore and it's the airport. And that was in February this year. And so there are some countries that are being cognizant of the impact and taken action. And so, you know, while many of us are seeing policies on the run, guidelines on the run, you know, what I fundamentally believe is that there is a lack of coordination in the development of the guidelines and also the developments of action. You know, we can be very nation-centric, local-centric, but at the end of the day, there are broader policy implications for what's happening now. So, you know, I'll show you in a later slide, you know, it was the NHS that has come up with a COVID decision support tools. You know, in the country that I live in, a certain public health official didn't see the need to collect data on race and socioeconomic data. Annual inspections in a part in Canada were scaled back in 2018. You know, the impact of COVID on family, on health professionals in nursing homes is unprecedented. And then I see the mafia is distributing food to Italy's struggling residents, and the good practice of Ireland. And there are many good practices, but what I see is that there's a lack of coordination, a lack of clarity around policies and guidelines, and because the narrative around the pandemic and the knowledge that we have around COVID is changing momentarily, you know, many of the guidelines and the policies are almost out of date before they get to the people and are acted on. Thanks, Lucas. You know, I wonder what we were doing before COVID-19. And this is an image of Korea. And, you know, the healthcare professionals were singing to those that were in isolation. Next slide. Thanks. What we know in Canada and many parts of the developed world are these terms: test, isolate and trace. And as I've said, they make absolutely no sense in low and middle income countries, you know, particularly when, you know, in India, 10 and 12 people are living in a tin hut that's 10 by 10. Makes no sense. And so what are the policies? No, can you go back? Thanks. You know, what are the policies and the messages that need to be there? You know, if social distancing isn't possible and water is not possible, you know, what are the messages? And I'm not the expert, but we certainly actually have to have different messages, and they are being formulated now. You know, the highest level of infection control in that environment, what is it? What does it look like? And how can we, as vehicles of communication, you know, communicate that out rather than just say, well, we don't know what to do? Because we have a responsibility at IFA and all other organisations and agencies to be communicators of evidence-based information. Because the rights of older people and those who are most vulnerable are human rights. And at the end of the day, governments, as well as civil society, academia and industry, will be accountable. Be sure of that. Thank you. Next one. Thanks, Lucas. Thanks. You know, on the left of the screen, this is the COVID decision support tool. And on the right, you know, another decision support tool that's been put together by Lifebox and WHO. You know, these are just examples of a multitude of tools that are being used. You know, but as I said, you know, I've actually got to ask the question, what's the decision support tool for and why is it necessary? And, you know, I'll talk about the systems that we're dealing with at the moment, but we need to be asking questions about what tool, for what environment, and for what population. I do want to make a comment about the WHO technical guidelines. And there's been a lot of discussion about the technical guidelines are not up to date, they don't meet needs, they're too basic, we need this, we need that. You know, there are 16 topic areas currently, and I know that there are more guidelines coming. Currently, there's 6 topic areas, and within that, there's 75 technical guidelines. And within that, older people are mentioned in brief and significantly 37 times. So I think we also need to step back and look at what is happening. And I'm very happy to be a critical thinker and a critical voice. But what is it that we can do to enable these guidelines to be meaningful if they're not, to inform the development of them, but be assured that WHO appreciates. We in the field may not think that there's a great enough emphasis, and I'll be part of that march post-pandemic, but now's the time to be supportive. Next, thank you. This slide is to remind me that in some countries of the world and in some local places, there are significant and substantive pandemic management plans. In Australia, I think there's less than 70 lives that have been lost. And in the long-term care sector, the aged care sector, you know, that's not the dominant proportion of those 75. And so going forward, you know, there is a need not only to look at good practice, but to understand the principles: prevention, preparedness, recovery and response. And that's not only for the older population, the more vulnerable, for healthcare professionals. You know, the thought that we have healthcare professionals saying that at the beginning of this pandemic, that it's okay to take their family and loved ones out of a nursing home, not acceptable. And while there could be arguments for it, I think we actually have to look at, you know, the system. Next one, thank you. Yep, and next one. No, back again. All right, this is a bit wobbly. No, back again. So, sorry, my instructions are pretty poor, Luke. That's it. Some of the slides missing, but really what this is saying is that there are a number of credible, evidence-based guidelines and calls for action. The problem that I'm having with the calls for action is we're doing it almost like shooting from the hip. And that's because I think many of us have not ever been in this position before. Lessons that we'll learn, certainly, you know, to be prepared, and not only to be prepared, but to take action. And so I'll be interested to hear from John and Sridhar and others how we can, going forward, you know, be more responsive rather than reactive to what's happening in the environment. Next, thank you, Lucas. This is a very wobbly slide. I apologise for that. But really what it's saying is, yes, we need more and more data, but we actually have to be acting at the same time as gathering the evidence and refining and repositioning, you know, our programs, our practices, and our calls for action. Next one, thank you. Okay. Yeah, keep going until we're finished, and that's it. Thank you. You know, the vulnerable human beings are all of us. When we're exposed to something like COVID, you know, I'm one of these white entitled persons sitting in an apartment that I can see outside, and my only complaint in the world is really that, you know, I'm not able to go to the gym in the morning. And from my perspective, that's pretty pathetic and shameful, because if I look even outside, you know, my bubble, you know, there are homeless people, sex workers still working on the street. There are older LGBT people laying on the street. You know, there are, you know, migrants and refugees. And so, you know, in my rear view mirror that I look at every day, the vulnerable human beings are those that, you know, are really don't have a door to move out of rhetorically. I wonder whether we need to be really looking at the broken, inadequate, and absent health, social, and long-term care systems. Many of us in this field have known these systems have been broken for decades throughout our whole career. But does it take a pandemic for governments to even do anything? I think my concern, one of my concerns post-COVID, you know, is the austerity measures that will be taken by many and most governments. You can't have stimulant packages of several $1 trillion without trying to find out how to recoup those dollars. And history has shown us that with austerity measures, the health, you know, investment is decreased. That can't happen because we have health inequity, and that will only increase and expand going forward. And while John mentioned, you know, well, vaccination is only one element. You know, John, you know, if 425 million people with diabetes, you know, who are vulnerable to COVID were vaccinated, you know, against influenza and pneumonia, and they didn't end up in a hospital that wasn't adequate to support their needs, you know, it may be a different frame of reference. So I do believe that going forward, we need to consider, you know, the whole vaccination field of influenza and pneumococcal pneumonia. And finally, Lucas, thanks. This is an important statement for me, and I will read it. Justice will not be served to older people globally if the call to action for significant investment in repairing and renewing the broken, inadequate and absent healthcare and long-term care systems is replaced with the word ageism. You know, this is a broader conversation, and there is no question that older people and those who are most vulnerable are being discriminated against. But there is a bigger conversation within that. It's not about allocation of resources. You know, it's not that. But we've actually got to talk about the rights of older people, the rights of vulnerable people within systems that have not been working for decades. And that's why it's so important that the decade of healthy aging goes forward, you know, with strength and with support from member states in the context of what we're learning in COVID.
Jane, you've had your time. You should wind up, please.
My last comment is, post-COVID, let us do it with honesty, integrity and authenticity. Thanks, Tom.
Thank you very much indeed. Fantastic, really helpful. And there you are reminded about the Global Conference on Aging. So can I turn now to Sridhar Venkatapuram and your 15 minutes, and please unmute and go ahead now.
Thanks. Is that working?
That is working fine.
Great. So thank you very much for this invitation to participate. I'm really, sort of quite moved by the invitation, and I want to address your sort of audience in the most helpful way I can. So just to give people who are watching a brief description of my background is that I'm a interdisciplinary global health researcher, and mostly I'm a political philosopher that tries to look at health issues from a perspective of ethics and justice. And so I have been responding at a variety of levels to COVID from an ethics perspective. And I think the number one question that any one of you have should be, what could ethics possibly do for us now? And, how helpful can it be? And is there a role for it or not? And so what I want to do in the next 15 minutes is try to do two things, which is that many of you probably have very difficult questions or difficult choices about practical decisions and actions that you are trying to do in the coming days right now. And what sort of reasoning, what is the right thing for you to do and how to reason about that. And then there are much more long-term issues that are playing out. So what I'd like to do is try to address both of those two things. I also would like to press upon everybody that is here today that one of the most important periods in sort of world history for a number of reasons. One is that it has the opportunity to profoundly shift the way that we as nations interact with each other and the way that we think about health in our societies and the way that we think about each other across national boundaries. And so whether we continue to let it go or whether we grab that and reformulate things, I think is really up on the table for us to think about. The second thing is that I do think that this pandemic is bringing to light that older people are at the center of this in terms of not only mortality, but various kinds of suffering of numerous scale, and also that older people, people with disabilities in low and middle income countries are going to suffer significantly, both directly from the virus, but also indirectly from the kinds of social responses that different countries have implemented, but also the long-term implications of the recovery process and what sort of neglect or what sort of policies that will be implemented. And they're going to be a huge number of consequences. And so I think it's an unprecedented time. It cannot be a let's go on as usual and let's continue to sort of soldier on. I think that it is a moment that we have to significantly going to rethink about equity and justice for older people in societies, particularly in the next sort of coming months, weeks, and years, what that impact will be and how to reorientate things. So starting with the most practical aspect of ethics and healthcare resource allocation, I think that what has been clear, and this is not an objective view, this is my view from my understanding of the issues, is that from the beginning, COVID, the social response to COVID has been presented as a resource allocation problem, which is that we, as the epidemic goes through our populations and we try to mitigate it in various different kinds, we're going to be faced with very difficult decisions about how to allocate limited amounts of beds, healthcare workers, ICU, and most narrowly, the debate became about we don't have enough ventilators and who do we give the ventilators to. Starting in late February, early March, various academics put out their proposed guidelines or decision-making sort of tree for how to allocate resources. And then beyond that, and I don't know, I've never seen this happen ever before, is this phenomenon where everybody started producing their own guidance or guidelines saying, this is how you should make decisions about who lives and dies and how to allocate resources. So in the UK, for example, you had almost every trust, you had the National Institute for Clinical Excellence, you had a variety of different organizations, and I know some of you are involved in this and some of you were involved in fighting it. But what I just want to say is that it is important for us to focus on the fact that the problem from the beginning has been framed as somehow a limited resource issue. This might be because of the example of Italy and what they were doing, but it also is, I think, partly because our language around ethics and justice related to health, and particularly older people, is so narrow that it only can think about it in terms of resources and limited resources. What that has resulted in, from my understanding at present in the last few days, is that in the UK, particularly in London, their hospitals are not over capacity, and that is because the EMT or ambulance drivers, but not the drivers themselves, but the individuals have been making difficult decisions actually on site. And so they've actually raised the threshold of which individuals to take into the hospitals, because so much of our debates has been about how there's not enough beds in the hospitals. So we have now a significant rise in deaths of people at home, but also from non-COVID related conditions as well. So in terms of why I'm bringing these practical decisions up, is that ethical decision tree guidance, and one of the initial reasons that I was asked to talk today was, what does that kind of guidance look like in a low and middle income country setting? And my response is, we need to be more careful about simply thinking about this problem as being a resource allocation problem. And much of the ethical guidelines regarding resource allocation in this pandemic, and in terms of ICU distribution, ICU beds and ventilators, as well as health policy in general during normal times, is biased against older people. And I want you to really kind of focus on that, is that there's no ifs and buts about it, is that most of the allocation decisions will be sort of as a result, in the end, older people will not get high priority on it. The question is, are the reasons good or bad in order to get there? And so all of us who are interested, are advocate and passionate about the rights of older people, really need to take a look at that bias within healthcare allocation, and particularly these pandemic sort of allocation rules. And so a lot of people say, no, we don't use chronological age, but what we use is different kinds of criteria, which often end up being proxy for chronological age. So the underlying issue, however, is hard to sort of talk about in just a few minutes, but I think that it's something that we need to think about. I would argue that one of the reasons that we have this situation is that there is an underlying ethical principle that most people find intuitively understandable, which is that when we have to make a tough decision, we should try to help as many people as possible. That is, that the greater the number of people that we can help, the better the situation is. And I want you to think about that very clearly, because in this COVID pandemic, that is the underlying reasoning for most of the policies, which is, what do we do in order to avert the most cases? What do we do in order to get as many people help as we want? What do we do in order to get as many people, in terms of not just numbers, but perhaps the number of life years that they live in this process? So this might seem for you very difficult, particularly when it comes to losing out of ventilators, but imagine what you would decide if you were making a policy decision across older people and saying, what is the right thing for me to do in terms of allocating resources among older people, and consider whether you would also follow what can we do to help as many people as possible, or whether you would have an alternative view. So I would leave that there. The second thing is that the transference of these kinds of guidelines, and particularly the underlying rationale in low and middle income countries, is not going to be direct, and it's not going to actually move as smoothly as we think. And that may be a good thing or a bad thing. As I was explaining to Peter, who invited me for this talk, most older people in low and middle income countries do not live in long-term care facilities. They live at home, or they live on their own, or they live together with other sort of non-family members. And they are very unlikely to go to a hospital or a clinic when they have difficulty with breathing or with other kinds of diseases. So the real issue here is, what is the right way for family members to treat older people at home in this particular situation? And what is the right way for community-based organizations and governments to treat older people when they are in these kinds of resource-poor settings or living at home? Those are difficult ethical decisions, not just practical decisions. The second thing, I think, is that we have to be really careful about applying or transposing the ethical frameworks and guidelines that have been developed in rich countries, or people from rich countries who want to think globally, and they've developed their fantastic decision tree that they want to apply around the world. So older people is one of those situations where some societies clearly value older people more than they do younger people for a variety of social, cultural, and historical reasons. And so these kinds of guidelines may actually go against the local values. So if I can press upon you the more sort of general point that this COVID pandemic raises difficult ethical issues beyond just clinical care and the allocation of resources, it fundamentally raises this whole question about what should governments and societies be doing in order to protect people's health. And right now, what is happening is that we've already made the decision in terms of what kind of policies that we're going to implement in order to protect the population. Now, the real question that for more countries are facing is, how do we remove the lockdown, and what are the decisions that we are going to use? So if you are an advocate for older people, one of the first things that we should be doing right now is considering what are the ethical principles that should be incorporated in the decision-making about reducing lockdown policies, and how should older people be protected during those sort of removal of lockdown policies. If we do not engage, as you will see in the Americas, where, particularly in the United States, where people are much more clear about the choices and they're not afraid to say it. So when they talk about the essential idea that there should be a sacrifice for the sake of the economy and protecting the economy and economic growth, that is a real, actual situation unless we sort of find and produce a new way of thinking about this issue. That kind of framing will dominate. And in that situation, once again, people will be talking about the greatest good for the greatest many, and how a few older people, may have to we may have to neglect or allow a few older people to die as a result because of the increased social interaction from trying to save the economy. I think that we also need to keep an eye on the long-term implications. This is low and middle income countries as well as rich countries have profoundly changed economic policies. By putting in trillions of dollars in order to save the current economy, they are now also going to be seeking to implement new kinds of economic reforms and economic policies. Right now in low and middle income countries, the economies are being devastated. Individuals who are already poor are being pushed into extreme poverty. So the new kinds of economic policies that will be implemented perhaps to pursue growth, and a growth at all cost policy will be incredibly detrimental to the poor, to older people, and to health systems. And so it is a really important time not only to think about now in terms of protecting and saving older people that are dying at home or in the hospitals, but also think very clearly and very quickly about what sort of economic policies should be allowed and which ones should not be allowed. And so that we can either entrench the existing kinds of inequities that have been produced over the last 10 years, or this is the moment that we build alliances so that you actually implement new kinds of social and economic policies that produce greater inclusivity and equity. Thank you very much.
Thank you very much, Sridhar, and thank you all of you for keeping to time. We have had a first set of questions from people, and I will read through these so that our panel can see what we're being asked to think about. So there was a question which was about a convention, similar, I think, to the Convention on the Rights of Persons with Disabilities. And the question really was that international organizations seem unconvinced as to the benefits of such a convention. Is it something we should be thinking about to protect the human rights of older persons? There was a question from a researcher about how they had a commitment to participatory research. How could they do participatory research in a post-COVID world? They'd had to postpone their, I think, focus groups with older people in Uganda. What would be possible in future? There was a question about social media. Can social media enable people from low and middle income countries to actually lead conversations? And if so, who are the key thinkers from low and middle income countries that we should be following? There was a question about how to deal with ageist policies. So those sorts of blanket policies that, for example, teachers over 50 should stop working. There was a question about how to influence policymakers. And there was a very practical question about how to protect older people where social distancing was impossible, basic masks were not available. And this applied particularly in low income countries, but also in some settings in high income countries. So a range of questions from folks. We can't ask all three of you to answer all those questions, but perhaps if there's any...
Tom, sorry to interrupt. It's Peter here. We were going to give the floor to Alex Kalashe just for a few minutes. And I'm sorry, this was a last-minute inclusion to make some...
Do you want him now
comments.
Or do you want him after the questions?
You know what? Because that was such a long list of questions and they're all very complex, to put it mildly. Why don't we give our speakers an opportunity to scribble down some thoughts and notes for a couple of minutes while Alex makes his public statement that I think is very important. So it's actually worked very well because they can think about that and then they'll be able to deal with every single question incredibly well. Okay, well then it'd be nice to welcome Alex Kalashe from Brazil to comment on the recent change of health minister and the health minister's comments in Brazil. Over to you, Alex. All the rest of us will mute our microphones.
Thank you. Can you hear me?
Yes, we can. Go ahead.
Okay, lovely. Well, first of all, thank you very much for this opportunity. What a difference 1 week makes. I was one of the speakers at the inaugural webinar last week, and here we are in a total mess in a country that was already doing badly, but now God knows with this new minister. I would like to start these remarks reminding you on the definition that Bob Butler, the founder of the International Longevity Center, which I now represent, when he coined the word ageism. And he said then that we are either black or white, woman or man, but we all aspire to get older. Unless, I would add, somebody decides to kill us because we dare to become old. I would also like to quote Albert Camus, who said in The Plague that the only way to fight a plague is by being decent, decency. And that is the situation that we are now. We are in a very polarized country with an ultra-right, I dare to put the name, really fascist government that has no respect for human life, that has impoverished the population, that has broken the health system, and now is looking with some degree of perplexity what they have done. I should add to the 3 wonderful speakers that we cannot look at ageism in isolation. We have to consider the overlapping with sexism, racism, remind ourselves that the most frequent victims of what is happening are black and brown and immigrants and minorities. We also have a context of poor phobia. We don't like poor people. They are dirty. They live in appalling conditions throughout the developing world. I'm speaking from Brazil, a country with unacceptable levels of social inequality. And so often they are blamed for the conditions they live with. Wash your hands, but we don't have water. Wash your hands, but we cannot buy soap. It is basic as this. And now we have a new minister who has good credentials of being very articulate, very intelligent, but he's a businessman. He doesn't have any training as a public health doctor. To the benefit of doubt, the statement that Peter showed at the beginning was not in his inaugural speech as minister yesterday. And the defenders say that it was taken out of context, but that is what he said, that we have to choose. We have to choose if there is someone that is old and someone that is young. So we don't have a protocol. It is going to be left for health professionals to make the decision. But the reality is that Brazil is in the front line. Pay attention to what is happening in this country, because it's going to be repeated throughout the South within this context of broken health systems, because for the last 4 years, what was not already working and functioning well has been sacked. Resources have been taken away, the universal health system under threat, because people like the new minister representing big business in the health sector are against having a universal health system. Jane quite wisely said that 3 key words are test, isolate, and trace. How can we test if what we buy from China, from South Korea to test is taken away when the planes stop over in Florida and they look at the content, say, you are taking this to Brazil. No, it's going to stay here. Confiscated conspiracy. How can we isolate, as she has put so well, if people living on top of each other in favelas without sanitation, without sewage, without water? How can we trace if our president himself probably infected because he went in March with a delegation from Brazil to kiss the hands of Mr. Trump, and 22 of the delegation came infected, he has refused so far to show that he had 2 negative tests. And he goes around in the ultra populist way, kissing his crowd, his fanatic supporters and followers, embracing them, taking shelves, going to bars to have breakfast with the crowd, the population. So that is the context in which we are. And I should just, to finish these remarks, remind, and I don't need to remind Jane because she was our partner at the time. I was the director of the WHO program on aging and health. And we commissioned 16 case studies looking at emergency situations throughout the world, from floods to tsunamis, earthquakes, and you name it. And in all of them, older people, yes, were seen to be vulnerable. But above all, they were seen as resources to their communities. They would bring the communities together. They could hold the communities together. They could see the end of the line, a light at the end of the tunnel, because they had gone through situations that would make them critical for their communities. And now we are thrown into the dustbin because we are old. I should say, in a very personal note, that I love my mother as much as I have always done, and she's 102. And more than ever, she needs care and protection. It's the protection of human life, whatever the age of this life is. As I hope and know that my children love me as much as they used to love me, now that I am 74. I think that we have the makings here through this webinar to launch a global action that will respect decency, that will respect ethical values and moral. After this pandemic, we cannot go back to the normal because the normal was part of the problem. I remind you that the mantra from the Silicon Valley was move fast and break things. After that, we will have to move more calmly and fix the things around us. There has never been a worse place and time to get older than Brazil at the moment.
Okay, thank you very much, Alex. Those are moving and powerful words, and I hope we can think of those and perhaps return to them in the next half hour that we have left. I want to divide the discussion into 3 parts. First of all, I want to talk about principles, and I'm going to turn to Sridhar first on this. What are the principles that should operate? Secondly, I'm going to ask you to think about policies and how can we resist ageist policies? How can we influence economic policies? Do we want international convention? These are the sort of policy questions. And thirdly, I'm going to ask about practices. And these practices might be about social media, they might be about research, they might be about alliances on the ground. So let me start off then by asking about principles. And for example, Sridhar, you criticized the utilitarian ethics of resource distribution, but what principles might we have instead of those? We also had a question about how to prevent ageism in a society where the young people want to lead the future. And somebody else said, what will be the impact of intergenerational solidarity if it's not maintained? So can we think then about some of the principles that we want to promote in this COVID context for, in particular, and with our colleagues who are older persons? Starting with you, Sridhar, and then with John and Jane, and about a minute or so each.
So I will put 2 principles out there. The first thing is that none of this is going to change, and we aren't going to move forward unless we start from a basic principle that every human being has conditions that support being healthy over the life course. Now the sort of certain few number of people to suffer or be neglected for the greatest good. So I think number one is the recognition of every human being has a moral claim to health and the conditions for health. The second thing is that we need to understand the concept that solidarity is not just an ambiguous concept. This pandemic brings to light that it's not just about what do I individually, what are my rights, recognize that social interaction can be harmful for us. People who work in social epidemiology know this understanding for a long time, that social hierarchies, social interactions, all these kinds of things impact health in a very direct way. Now we can see very directly that social interactions actually also can be running risk to our life and suffering. Therefore, we should think about solidarity as the concept that says that we all share vulnerability through social interactions, and that we can protect ourselves from risks like this, but we can actually produce more human well-being through cooperation. And so I think those two things would be my starting principles for what should be the principles that guide our action.
Thank you very much, Sridhar. Can we go to you, Jane? We're still on principles. We've talked about the ageism also out there. And how we can maintain intergenerational solidarity. Have you any thoughts on any of these topics that you could share at this point briefly?
Yeah, look, thanks, Tom. I go back to the basic one, which is the rights of older people are human rights. I just would like to just make the example that, we are calling retired healthcare professionals back to work. And it seems to me that, we do this push-pull around rights when it suits the particular situation. I also feel as though we need to, if we're going to think globally, we need to put that lens of social interaction. When we're talking about that, we need to think about what that actually means in low and middle income countries, because I think that we have something to learn from them, in terms of the rich countries that we live in. So I'll leave it at that, Tom.
Thank you very much. And John, for you, finally, briefly on principles, why do you think international organizations seem unconvinced as to the value of a convention on aging? Do you think that's a priority in terms of setting out principles?
I think a convention would be helpful. I don't know if it's the be all and end all. I mean, I look at disability and I see it's been a very useful tool in that field. But I'd just like to come back to the principles, because I think what we should be fighting for is to try and create resilient and equitable systems, whether they're health systems or broader social systems. And to do that, we need to be strengthening some of these institutions. Now, a convention might be one way, but we need to be strengthening the international organizations like WHO and also some of the institutions we have in our own countries. We need to also be strengthening the scientific technical base, which has tended to be neglected over the last few years in the drive towards populism. And we need to be strengthening the mechanisms we have for social solidarity. But I think there's one point, we've talked a little bit about equity, and I think something we mustn't do if we're moving towards this is to base a lot of decisions on either chronological age or on multi-morbidity. And because particularly multi-morbidity is inherently inequitable if we use that as the basis of rationing treatments or prevention. So, for example, one of the biggest drivers of multi-morbidity and poor health is poverty, and so somebody's being a low socioeconomic status. And so if we're rationing services on account of people being sick, we're actually discriminating against people on the basis of their socioeconomic position. So I think we need to be thinking of better ways of doing that and doing it very quickly.
Tom, could I just make another point very briefly?
Sure, go ahead.
If we're talking about a convention, to say that it is helpful, I think is a gross underestimation of the power of a convention and the current situation that many older people experience on a moment by moment basis around the world. We're now in our 11th year of the UN open-ended working group on aging, where member states are coming together and discussing, the potential and the possibilities and the importance of a convention. So I really believe that, this time, in the pandemic, that it's about collaboration, cooperation and solidarity amongst international, national and local organisations around a convention. So I feel very strongly that we need to be coming together, because, the Convention on the Rights of People with Disability has certainly made a profound impact on some in the world. Thanks, Tom.
Thank you very much indeed. Now we do have limited time, so let's go to policies. So there are questions about how we can have better economic policies, how we can deal with blanket ageist policies, for example, about teachers over 50. There's questions about how to influence policymakers. And I want to highlight a recent question, which was about basically about guidelines. What guidelines exist to lessen ageist attitudes among healthcare workers, which is prevalent in countries of the global south? So can we have a little think about those policies, economic or policymakers to influencing them, or blanket policies about employment, or indeed policies to lessen ageist attitudes? So I think I will go back to John and then Jane and then Sridhar very briefly to comment any of those that are relevant.
Okay, well, you've certainly put a few out there, Tom, but I think if we think broadly, a lot of the challenges we're facing comes back to the utilitarian approach, which Sridhar sort of talked about, which has then led to the framing of the issue here as a resource allocation problem. I think what we need to do is move beyond gross domestic product being the measure of a country's success, and actually look at much more meaningful measures of social solidarity and what is the kind of society which we would want to live in. I think once we start from that point, then we can start looking at all the different pieces which would comprise that. But if we don't completely wipe away that slate, that everything is basically economics and success is measured against economic success, not social success, then I don't think we'll get anywhere.
Okay, John, thank you very much for that comment. Jane, could you say something about those policies, perhaps particularly about how we can have anti-ageism work strategies for healthcare workers in the global south?
Look, Tom, I mean, I think, what we know is that it happens at a national level. And quite frankly, if we can't do it for the North, how are we going to do it for the South? These are the poorest paid people. And what we're seeing is the poorest of the poor are paying the highest price. And so, it means that advocates, like Help Age International, who are really at the coalface, working, age demands action, working at the coalface, it's the influences of civil society that help political change. But I just also want to make the point in terms of healthcare spending. Recent OECD report said that only a fraction of health spending is allocated to prevention and promotion. So when we're developing, new policies around health, there needs to be a significant investment, in prevention and promotion. For example, many European countries, it's below 9%, and vaccine spending is less than 1%. So I think we've actually got to look at, the gamut of healthcare spending. Thanks, Tom.
Thank you very much. Sridhar, policies then, how to, you talked about economic policy. And there's also questions about how to influence policy makers. Have you thoughts on some of those? Sridhar, I can't hear you. Are you muted?
Sorry. I started talking without turning it on. My apologies. So very quickly. So I think that what's happening, if I can describe it on the policy level, is that the immediate and dominant policy in dealing with COVID has been a contain and control approach, which is that the primary aim of everything should be about how do you contain the infections, how do you control it, and how do you then provide care for people. And that has been only single dimensionally. What we're interested in is that curve of cases, of deaths, or curve of infections. What has done that has allowed us to then be blind to the numerous kinds of deprivations that have occurred in all these other dimensions. So one of the first things that we need to do in terms of policy making and advice is to start taking a multidimensional view of this, which is, on the one hand, you have cases going up in a curve or coming down or flattening, whatever that might be, but also look at all these other dimensions, whether it be all the different kinds of life that we have been constrained with, but also thinking about groups of people in their different age categories, and older people are profoundly impacted. So we need to take that multidimensional view of it. The second thing is that I would say that wherever you are in the world, you must engage with the policymakers in whatever way that you can. And if you disagree, this is the right time to disagree with them, and also engage with the journalists and the media, because this is a time when their voices and views are actually very loud. And so we need to be able to shape the debates wherever we are in the world.
Thank you very much indeed, Sridhar. So the final round, if you like, of thoughts was really about practices. And we had a question about how participative research could continue post-COVID. We had a question about social media. How can we listen to people from the low middle income countries, particularly key thinkers? Who would you recommend that we should be following on social media? And then finally, how can we protect older persons without having sufficient test kits, masks, and avoiding social distancing, which was very much a reality, not just in middle and low income countries, but also high income countries. So how can we protect? How can we listen to, who should we listen to on social media? And the research, how can we do participative research in a post-COVID world? So let me go back to John then. Any thoughts you have on that, John? You've probably got about a minute.
Okay, Tom. Yeah, I mean, I think just coming to what you can do in low and middle income settings, I think it's universal precautions, doing as much as you can to provide physical, not social distancing, but physical distancing, to ensure that somebody who you think may be vulnerable has the minimum possible exposure. That's about all that can be done at the moment. But I'm very hopeful that some treatments will soon become available and that a vaccine will eventually be available. The real question then is, how do we ensure the equity of the rollout of those treatments and preventive measures? Because the risk will be that, in fact, those at greatest risk in low and middle income countries will be the last to get access.
Thanks, John. Can I turn to Jane? Would you address any of those points that we had?
Look, the go-to organisation for IFA is Help Age International. You know, they're credible. They've got the, you know, they have older people telling their stories, and they're one of the great influences of our time. So anybody that wants to follow those that in the know, you know, I would suggest Help Age International, and of course IFA and yourself, Peter. But I think Help Age International has certainly got a strong voice and is right at the heart and the coalface. And I would agree with John's comments.
So very quickly, my thoughts is that We should be focusing and finding those organizations that are working on health of communities that are living in rural areas, which are working with minority groups and other socially excluded groups. So for in India, there's something called the People's Health Movement, and then there's also a variety of groups that work around ethics, and they have been doing a lot of incredible work around advocacy and identifying and engaging with the government. So that's one sort of place. I think we also need to be looking at people who are thinking about the economic and social policies after this in a variety of different countries. You will find South Africa, there's different examples that are taking shape where people are advocating for a variety of different things. Latin America, I have not seen very much, but I think that if we follow Alex, we will get a lot of different kinds of networks that are going on. So there are definitely a lot of LMIC advocates, activists, and thinkers out there. We are at this point also fighting, I think, the bigger problem of the domination of global health discourse by people from rich countries. So I think it's one of the things that we need to do is to be able to ensure that we lift up the voices of our colleagues from the South.
Thank you very much. And I think that there were thoughts about social media, and it seems to me that often older people, certainly the people with dementia that I work with, are ahead of the game on things like Zoom and other social media and interaction platforms. So they can show the way in many cases. One of the good things that's come out of this terrible epidemic is that we are connecting like never before across North and South and across countries to have these dialogues, and without an impact on the environment. So I think we are not going to go back to the same world, and it's up to us to make sure it's a world that fulfills our goals in terms of equity, inclusion, solidarity, regardless of disability, age, gender, and these other questions. I think at this point, I really want to thank our speakers today, John Beard, Jane Barrett, Sridhar Venkatapuram, and of course, Alexandre Kalache, who've been really, really effective in making our thinking more focused. And to thank Lucas, who's been organizing all this all. I want to ask him to bring back the PowerPoints and to ask Peter to talk us through the next steps from here, which is both the upcoming webinars, but also how all of you participants can get hold of the information that we've been sharing today. Over to you, Peter.
Well, thank you so much, Tom. I think you've done a fantastic job of chairing and moderating this session, and equal thanks to all the participants and all the speakers. My head is spinning. There's so much for us to think about here. I'm just going to very briefly run through. Lucas, I can't see the slides. It might be I'm following this on YouTube, but there's a delay.
There are slides here, Peter. There are.
Okay, right. If we can go to the slides, forthcoming webinar series, which is the one after the happy
That's
pictures.
The one that's up at the moment, Peter.
Fantastic. Okay, so you can see there are lots of topics that are going to be coming up. We're going to try and run one webinar a week. We might even do more than one webinar a week. All of this information is going to be put on a dedicated tab on our website in the next few days. So watch this space. Next slide, please. We do have more specific information about the next webinar. Please bear in mind that it is not going to be at 12 o'clock UK time on Friday. It will be at 2 o'clock UK time on Friday. That's because there will be a separate session, which I'm going to talk about in a minute, which is being organised by IFA, International Federation of Aging, and otherwise this would overlap with that. So the focus will be on older people, comorbidities and COVID, so another incredibly urgent and important issue. We've got a range of different speakers looking at dementia, non-communicable disease, and I think we'll also have somebody talking about infectious disease, HIV. Next slide, please. This is the event that I was referring to that will also be taking place next Friday. Again, you can see the ubiquitous Alex Kalache will be talking about COVID and older people in low and middle income countries. And you can access information about that on this hyperlink. Next slide, please. I would like to thank not just Lucas and Tom and all the participants today, but as I said at the start, this is a slightly ramshackle bunch of people who are mainly doing this on a voluntary basis with very, very few resources. And it really is amazing. I mean, this, you know, we've run this webinar probably for less than £100. So it's amazing what you can achieve with small amounts of money. However, we are desperate to get funding because we have almost run out of our funding pot. So if you like this, if you like our website, can you please help us find some funding? We were knocked back from Medical Research Council yesterday. We asked for £300,000 to develop these activities because they said that our activities were not sufficiently relevant to UK interests, which was disconcerting. One last thing, clearly there are so many things that we could do just with regard to ageism moving forward from this session. And I have some suggestions which we will share through our networks, both on the website and mailing list, about how we do move forward. One of them is that anybody who's interested is very welcome to email us, and I will circulate an email address, one-page contributions about ageism and health and or coronavirus. Please give us your name, your affiliation, and an email contact. Just one page. By the end of Monday, if we get some of those, we will simply compile them into a single PDF document, and we will put it on our website under a new tab, which will be a dedicated tab on ageism. Secondly, we're hoping to produce an open letter, and we will approach all of you in terms of whether you're happy with the content of that letter and whether you would like to be co-signatories. So watch this space. Thirdly, I think there are clear grounds for considering establishing some kind of new body, some new entity with an exclusive focus on the issues you've been discussing today. I'm going to see if we can help kickstart that process. And again, through our mailing list and our participant list, in a day or two, we're going to send out a simple form, which will allow you, if you're so interested, to nominate yourself to be somebody who would be one of the leaders in this new initiative. And we will ask for a small amount of information about your experience and your influence, what actions you think would be most important, and how much time and resource you would have to be able to take those actions forward. If we get too many people self-nominating, we will then try and develop some democratic process across our network to select a small group who will lead on this. We will then link into those activities through our tab on ageism that we're going to set up on our website. And clearly there could be a whole range of things that are taken forward there in terms of some people talked about a convention, or maybe just more generally some kind of watchdog role, which is being very vigilant about forms of ageism, or thirdly, some kind of think tank, which is able to think through some of these very, very complex ethical and practical and policy issues. Okay, I'm out of breath and I'm out of time. I would like to leave the last word to Tom, because I think he's always got very interesting things to say, and he's done such a great job, and he's been very, very good at not really talking very much and just facilitating other people's participation. Tom has a wealth of experience in areas of disability and old age and rights, and I'm sure he can make the most of the last minute before this Zoom session ends. So over to you, Tom.
Thank you, Peter, for dropping me in with that one. What I would say is that we need to hear the voices of older people. In our work on disability, we've been trying to hear the voices of disabled people, and whatever we can do as a network to hear those voices and promote those voices and the rights approach will be of value when we're setting policies, setting principles, and developing practices. So alliances with organizations led by older people would be really helpful in our health policy, economic policy, and in any discussions we have on rationing, which cannot be the utilitarian discussions that Sridhar was criticizing. So very much hope that you can join with this network in that activity. We need to be aware of what's happening from the top. As we heard from Alex in Brazil, there are other worrying signs. And the more that we can challenge, the more that we can get a better, more equitable and solidarity-based approach. We did that in the UK when there were discriminatory guidelines about resuscitation and about rationing. So sometimes these is, I'm afraid, just an error rather than a conspiracy. And if we're there to put that view, put that rights-based approach, then hopefully our voices will prevail. And good luck to everybody on this call. Thank you for participating.
Thank you so much, Tom. And to everybody, stay well, stay safe, stay sane, and stay in touch. Goodbye.